Unmute.
There's two NLDs.
That's you.
Video too. Good. All right, folks. Good evening. It's great to have everybody here. It's a little weird to talk to a big TV screen and only see like three faces, but I'll do my best to push on through. So we're here tonight to present about the new MCP MOU changes. Just so everybody's aware, the meeting is being recorded. We are going to share the recording and all the slides that we're about to share with all the members first thing in the morning. If you have questions, we're going to ask you to either raise your hand. There's a raise hand button on the bottom. And Krista, who's off to the side, will get those questions. Or you can type them in the chat line on the bottom as well, and we'll get to those questions as we go. We'll probably push on through the whole presentation, and then I'll come back to questions right at the end. It's probably a little easier. It'll probably make the flow of the evening go a little better that way. So, Krista, you can start to share the slides. So if someone could just give a thumbs up in the chat line to make sure that they're seeing the shared slides. We just want to make sure that everybody can see these slides now. Good. Okay, thank you. All right, so the first thing I want to do is just remind everybody where we are right now. So next slide, Crystal, please. So this is the current MOAs that we have. These are just highlights of what we currently have in place. So everybody will remember that the last MOA was negotiated in 2022. It expires tomorrow evening. So currently, clinics can only claim to a maximum of the 2022 NLDA suggested fee guide. And we can only claim the unpaid balance from private insurance up to that maximum as well. So we can't claim past 2022 for any of the suggested fees. We did get approximately 90% of 2022 fees back in 2022. That has now gone down to, we're at about 78% of the 2026 fee guide right now. So other highlights, because they're going to change, we currently only have codes for amalgams in pediatric patients. And part of the negotiation that we went through with the government was to try to stress how large an administrative burden MCP claims are because of the system that's being created by government. They saw light in that. Hopefully what we have to present tonight will help alleviate some of that administrative burden. We think we've accomplished a fair bit more than we could before. So without further ado, on to the next slide. So we went in with a couple of objectives in order to get our new agreement. The first was that after an analysis of all our codes that MCP has, it was determined that because of the way the past agreements had been negotiated and how fees had been structured, some of our fees had lost quite a bit of traction and quite a bit of ground compared to what they were supposed to be. So normally what had happened with these negotiations would be that government would give us a set raise increase in year one. So back in 2022, it was about 23%. And then they'd give us 0, 0, 0 after that. That works out okay if our fee guide were to be raised across the board with every fee getting the same raise every year, but that's not the case. We have differentially raised certain fees in certain sections of our fee guide over different times based on recommendations from the tariff committee. So there's been differences in fees that certain fees, for example, preventative has been getting less of a raise compared to restorative fees. So that's caused a disparity in the fees. So one of our first objectives with the new MOAs was to have a complete reset of the codes back to the intended 90% of the 2026 NLDA fee guide. So with the help of our statistician, the good old Dr. Shane Roberts, he went through each and every individual code, determined what the raise, what the percentage would have to be. We shared that with government, and they were agreeable to that. So there will be a differential raise in codes right across the board, but the end result will be that all codes will now be raised to 90% of 2026 NLDA suggested fee guide. There will be no deletion of codes. You will see some new codes in a second here once we get into it. And it's very important to remember that, and this is not new, this was being treated like this before, but it's worth noting that CDCP patients will be treated like any other insurance patient or insurance company. So that will become important once we move on to the next slide here. So one of our first big wins with government, and one of the things we've had trouble with over the 4-year course of the MOAs and MOUs is that we've had deterioration of the fees. Like I just said, what happened in 2022 was we ended up close to 90%, but by the time we get to the 4-year end of it, we're down to about 78 or 79% right now. So that's a real problem. So we've asked government, and they have agreed. So for patients with insurance, and it's important that we, as I say, we're going to share these slides, but it's very important that we differentiate between the categories we have here now. So for patients with insurance, the clinics will be able to bill the residual amount that the insurance doesn't pay to MCP for that current year's NLDA suggested fee guide at 100%. So what that means is that in 2026, we will use the 2026 NLDA suggested fee guide. 27, we'll use the 27 guide, 28, 29, and all the way up to 30. What that means for us is there will be no deterioration in our fees whatsoever over the course of this whole MOU. This is the first time we've been able to balance bill MCP since the inception of this plan. So this is a huge win for dentistry. This represents approximately 70% of the patients we treat in our clinics have an insurance coverage. So what will happen now for our pediatric patients who have insurance is that the claim will go to the insurance company for 100% of the suggested fee guide for that particular year. The part that insurance doesn't pay will then get billed to MCP, and MCP will pay that difference to us up to 100% of our suggested NLDA fee guide for that particular year. So as I say, this is certainly the biggest win we have in this contract. This changes the whole dynamic of how we're billing MCP and how we now have coordination of benefits with insurance companies. Second to that, and because CDCP, and as I suggested in the last slide, because CDCP is treated as an insurance company, those patients who we see who have CDCP, whether they are pediatric patients or under the adult dental program, we will be able to balance bill that portion that's not covered by CDCP for the adults up to the maximum of $300. For the kids, it'll be, there is no maximum on the pediatric side of the things. But that particular patient pool, once again, represents another 20 to 25% of the Newfoundland patient pool. So that leaves only about 5 to 10% of the patients that are going to be treated the way we treat all patients right now. So that is an absolutely amazing thing that government has agreed to do for us. It is something we went in hoping that they would see the benefit in. Other jurisdictions have been able to get this full coordination of benefits. We are extremely happy to be able to report this back to the Newfoundland dentist. For our CDCP patients, we have, in concert with the federal government and the provincial government, agreed to help promote this particular plan to all our adult dental program recipients. So right now, currently, there are approximately 22,000 or so Newfoundlanders who receive income support through the adult dental program. every single one of them qualifies for CDCP. Because our program has a much lower threshold than CDCP. If you have the adult dental program, by virtue, you qualify for the CDCP. We need to get all of those patients moved on to CDCP. What we heard through when we were talking to members who have been treating these patients was there was some reluctance for some certain patients to move from adult dental program to CDCP. There was an apprehension that they might lose one. That's not the case. The provincial government has assured us that there's going to be no depreciation in the adult dental program because of CDCP. There was also some reluctance because with the adult dental program, that $300 they paid $0. So we've alleviated that by coordinating the benefits between CDCP and adult dental program. So what that means is that approximately 80% of the care will be covered by CDCP. The other 20% will be picked up by the adult dental program. So in essence, these patients can now get approximately $1,500 worth of basic dental coverage without having to pay any expense out of their pocket. That's a huge win for this patient pool. So we as dentists in our office will have to be promoting this program to the best of our ability, helping these patients get signed up for CDCP and moving this program along. I suspect there may be some questions on this. I'll come back to the slide if I need to, but I'll keep going. But this is definitely the biggest change. This is a monumental shift from what government wanted to do before, where they didn't want to have it at 100%, but now we've been able to accomplish that. Next slide. So I've broken this into 3 different areas. These are the new things that are going to be added and some things that have been taken away to make life easier for everybody. So this slide will show some of the basic things that general dentists will be interested in. And of course, our specialists will still be able to avail of this. But I do have a couple of slides that are almost exclusively for our specialists. So we've been able to negotiate in that panoramic x-rays will be covered once every 5 years. We no longer have to get predeterminations for root canal treatments on permanent anterior teeth for our 5 to 13-year-olds for trauma or caries. However, MCP does reserve the right to go back and post-treatment verification. So I would encourage patients or encourage providers to be sure to make sure you have x-rays of these teeth. They may not ask for them, but if they do, that's your go-to. Tooth needed a root canal, make sure you have an x-ray that proves it needed a root canal. Surgical extractions under the adult dental program, including third molars, can now be performed by general dentists. No questions asked. We have the removal of the remarks code for emergency exams under all 3 programs, so there will be no more remarks codes required. We've asked for the claim submission time to be increased to 240 days. This was in order to part and parcel because of the coordination of benefits, because the patients have certain kids will have 2 lots of insurance that have to go through first, and then finally MCP. We have to remember that MCP is the payer of last resort for all of the other insurances that they have or other payment methods that they have. We have been able to better align with the standard of care. We will be removing the word cleaning, and we will be establishing a scaling code and a polishing code more in line with traditional dental offices. And we will be separating out amalgam and composite. So we will be getting a new set of composite restoration codes. They will carry the same value, both amalgams and composites, but this just better aligns with what exactly we're doing when we do restorative work on our pediatric and or adult dental patients. Next slide. The one code that we weren't able to get to full fee is our stainless steel crown code. This has been an ongoing battle and will be picked up on the next round. However, this code has not been increased since 2018. So it's sought at 90% of 2018 fee guides, which is approximately 56% of 2026 fee guide. So we were able to negotiate with government to have that fee raised to 75% of the 2026 fee guide. Now that's, of course, only for the patients who have none of the other above criteria. So if they don't have insurance and they don't have CDCP, then this is where this would fall into. The other categories for our specialists who are treating and our general dentists who are doing a lot of stainless steel crowns, you would still treat this code the same way you would any other code if the patient has insurance. It would be billed 100% to the insurance, and then MCP would pick up the difference that insurance didn't pay up to this amount. They won't go over that 75%, but I don't think you'd ever get to that higher rate. Our specialist rate is also included in this slide. That rate will stay the same for the whole 4 years. That fee will not increase for the next until 2030. But like I said, that is a very small portion of the population that that falls into. At the request of the pediatric dentist, government will allow zirconia crowns to be placed on primary canines when billed by pediatric dentists at the current level of a two-surface composite. That's directly from them, so they asked for that, and government was happy to avail of that. For the oral surgeons, under the surgical dental plan, once we did survey the oral surgeons to see what exactly they wanted out of this new negotiations. So one of the things they wanted to see was a code created for recurring patients for ongoing care in their office that has been established. So that's, for example, cancer follow-up patients who have ongoing care at an oral maxillofacial surgeons. No limitations on that code, how many times it can be used. It'll be a per visit code. The surgical dental plan will only apply when surgical extractions are performed by the OMFS in their office or hospital settings, and only for patients not on income support. That's pretty standard. That's already been in the plan, but we wanted to reiterate that. The removal for 2 courses of antibiotics in order to have teeth removed under the surgical dental plan has been removed. That does not align with the standard of care that exists. So if you see infected wisdom teeth once, that's more than enough. You don't have to wait for the second time to have it referred to an OMFS to have this taken out. Finally, OMFS asked us to establish a codes for CBCT. So they will be getting a code for acquisition and interpretation of CBCT. That's only the OMFSs. So that was a standard of care that they thought they needed to have, and government saw fit to see that as well. As far as timelines go, there was some delay in getting these negotiations started. Government changed hands. We were ready to go in October. Government changed hands, of course, with the new election in October. It did take them a fair bit of time to get up to speed with all new ministers and a lot of new staff that were brought on board. We did present our side and had our stuff ready to go early, but it did take a long time to get back to us. I do want to thank, and she's not on the call tonight, but our provincial dental officer, Dr. Michelle Zwicker, and her boss, the director of medical and dental services, Mr. Dave Moores. They did a tremendous amount of work on this behind the scenes, trying to move this along. They knew full well that our deadline was April 1 and that we wanted to have this in place. So it is now done. The MOUs are going to be signed within the next week or so. However, the system won't be updated with the new fees for at least 2 to 3 weeks. So my direction and the direction that I spoke with Dr. Zwicker earlier this evening that we're going to give providers is to hold claims until we tell you that the new codes have been put in place, or the new fees have been put in place, sorry. Like I said, they anticipate that should be by the middle of the month. And then all the claims can be submitted. Then we do have 240 days. So you can still bill the insurance companies for the pediatric patients that you're doing, but you do have to pull back for the remainder from MCP. The new codes are going to take a little bit longer to get effect. MCP has to generate those codes, and then the descriptors had to be added to them. So they're telling us it's going to take 2 to 3 months to get the new codes ready to go. Once again, you can still treat these patients. The direction that I've given you tonight is going to take effect on Wednesday. So if you want to take a panoramic X-ray on a 5-year-old on Wednesday morning, no problem. But you do have to hold that. You will have to hold that a claim until we actually get the code from MCP, and then you can submit that claim. Make sure you hold all the information. So you're going to need to know the patient's name, the date you did the date of service, and what you did, of course, and then you can submit the claim accordingly. But we do have some time there is going to be a bit of a lag in getting this up and running, but I think we'll be, for what we're going to get, we're probably going to be pretty happy with the wait. I think I'm just going to pause right there because the next bit is about the other two parts that are to this. But are there any questions on the MCP stuff before I go into the new bursary and the recruitment issue? If anybody, you can raise your hand. Crystal can see, or if we have any questions in the chat box, I'm happy to answer. Or if everybody's completely confused, that's fine too. Nothing? Wonderful. Everybody's just saying, they can't imagine that we got all this stuff. Next slide. So this came out in the press release on Friday. We knew it was going to come together. This is not part of the MOUs or the MOAs that we signed. This was a separate initiative that the association took on. We've been sitting on this for about 3 months. We knew this was coming. We knew we had funding already approved, but government wanted to wait to announce all this on the same day. So we've just been sitting on it. So this is just a straight addition to our bursary program that exists. So instead of it being 10 right now, we will get 15. So this is just a $250,000 increase. It falls under the exact same rules we're using right now. We'll be able to we'll have 15 students on bursary every year, over different years, of course. So that doesn't mean we're going to get 15 students back every year. It'll probably equate to somewhere between 3 and 5 per year returning. But yeah, this was just a straight increase in the number of bursaries that we currently have. So that one is pretty straightforward. And this is the final slide, and this is the new program. So this we spent about 6 to 8 months developing this program in-house, and then we presented it to government. So this is a rural dental retention program. This will be the first of its kind, I think, in the country. Once again, the initial funding will be 10 at $25,000, so a total funding of $250,000. We are still working through the details. These are the details we know for sure. You have the work in underserviced areas, very similar to the bursary program. Right now, the objective of government right now is to limit it to past student bursary recipients. Where that may or may not be the case, depending on how many applicants we get for this. It will still be the same required 400 hours in a 12-month period, similar to the bursary program. You can get up to 5 of these total. If this is the exemption here, if no bursary recipients remain in the practice area if needed, the bonus will be extended to licensed dentists who agree to provide service in the designated areas and has not received a bursary if funding allows. So that's the sort of the kicker there, that the dentists who go to underserviced areas, whether you had the bursary or not, it's going to depend on whether we get enough past bursary recipients. You may in fact be entitled to one of these retention bonuses. Over the next 2 months or 3 months, we're going to work with government closely to develop the application process and get these out to members. And then the objective, I said by the end of the year, but I do think that government would like to see this out a little bit earlier than that, probably into September or October. Michelle will be the one who will sort of determine the timeline on the delivery of these. I know with bursaries, the new bursary money will be available in September. That's already available now. So we will, when they give out bursaries in June and July, they will be giving out 15 instead of 10. So there will be 15 students who will now receive bursaries from Newfoundland. The retention part of it, as I say, the application process and the actual contract that the recipient will have to sign with the government is yet to be developed, but it will be very similar to the one that's online for the bursary. So if people are interested, you can go to the government website. The bursary contract is available on the website. It'll have similar language and similar requirements that the bursary program has. So that brings a grand total of $1 million that the provincial government will be funding for recruitment and retention in dentistry for the foreseeable future. So we think that's for a small province like ours, that's a pretty big win. We're pretty excited to get all this new money sort of thrown at us or laid on our lap, and hopefully we can make good on it, and it'll be a win for the membership and also a win for the patients, because of course ultimately that's what this is going to end up being. It's going to be an access to care issue, right? So we're going to be treating patients in their hometowns and in their home communities, and that's how we're going to, if and when we're asked, that's how we'll sell this program to the general public. So that is the last slide I have. It's a fairly quick presentation, but it's important that we get everybody on board with this. Like I said, we will be sharing all this. Are there questions or? Okay, good.
The code for OMFS for recurring patients for ongoing care. Is that only to be used in clinic or also for follow-up in hospital for post-op care? There's two questions. That's the first.
We'll have to clarify that with government, but I think their intent was for it to be in office.
For infected wisdom teeth to be covered, is it only the one wisdom tooth that is infected, or will it automatically include coverage for all 4 wisdom teeth if one wisdom tooth is infected? Also, does it have to be an active infection or just infection observed by some point by the OMFS, or can it be infection reported by the family DDS?
Well, it can certainly be infection reported by the family DDS. Whether or not they will cover all 4 out with only 1 infected, that's a question we'll take back to government. I don't know the answer to that one. Yeah.
That question, those questions, and they said thank you.
You're welcome, Becca.
And, someone else asked, can the sites that do not have bursary candidates be given priority?
Sorry?
Can the sites that do not have bursary candidates be given priority?
For which one?
Bursary. For the, it just said for the bursary.
For the
And sites that do not have bursary candidates be given priority. So communities that don't have.
I'm not sure what the question is, but if it's for the extra bursaries, they will be treated the same as every other bursary. So they will be given no more priority than anybody else. So if you have a satellite clinic that you're trying to get serviced, then there's a process to getting on that list. And I think people who have satellite clinics know the process. And it's certainly, we send out a survey in every year. We ask for names of clinics. We generate the names of clinics. We give them to government. Government then goes down through the list and makes sure those clinics are full in concert with us. So we sit with government and figure out where clinics are in need, and then from there we determine where the bursaries are available for that any one year. I think that's what the question is about. Okay.
What does that completed bursary mean? Does it mean that the return of service should be completed before they're able to apply?
Yes. Yeah, you can't get a retention bonus if you're still fulfilling your bursary requirement. This won't take effect. So if you have a 3-year bursary, you can't get a retention bonus until you're already under contract for those 3 years anyway. So this is after that is done.
He can answer the bursary question, he said.
Oh, okay. Can you make him talk? Dr. Redmond may appear here in a second.
Great.
Oh, yeah, thanks. Anyway, get Becca's question when she asked about the wisdom teeth. The rules are unchanged, other than the fact that you'll need two. You don't need lots of antibiotics before. So whatever the rules were before, when somebody that had infection, whether it was one wisdom tooth or two, or three or four, that's going to be the same rule. That's unchanged. And for SNEA, she was asking if places that currently do not have bursary students will be given priority for the retention ones. The way it's going to work is that the program is not going to find the retention bonus students or dentists for the clinics. So if you have dentists that's servicing an area, they can apply. And if there are set rules on the order of priority, previous bursary students are first, and it goes down from there. But if there was more than 10 apply, then let's say if there was 11, then the locations would become a factor. But the students are not applying and then being put into places. So it's like the clinics have to have the person to apply. They're not going to find them for you. But places that have no dentists at all would be given a priority over a place that already has one bursary student going to it. So I hope that if that answers the question or not completely, but so you do need to find the dentist yourself. The program won't find them, but once you find them, they can apply. And if they were a previous bursary recipient, they're going to be given priority.
Yeah. And further to that, Sneha, if in fact there weren't enough prior bursary recipients to fill all the retention bonuses, and you, or anybody else who wanted to go to an underserviced area and fulfill those 400 hours, and you were number 8 or 9 on the list of 10, you would in fact get the retention bonus then for doing the work in that particular underserviced area. But that is the lowest priority. There are 3 or 4 steps above that one that would qualify for the retention bonus before a practicing dentist in a large urban center would qualify for. Okay.
The patients without insurance,
Yes.
can we bill the NLDA fees and charge the patient the difference not covered by MCP?
No. We're not allowed to balance bill for those patients. You will only be allowed to bill to 90% of the 2026 NLDA suggested fee guide for the whole 4 years. Okay. If everybody is,
The question is not for retention, but to get it.
okay, so I'm not sure, Stan, but we certainly can talk privately, but there's nothing in this that commits the government or NLDA to finding candidates. This is simply help with there will be more of a pool of candidates now because we will have 15 bursary students as opposed to 10. So by virtue of having more, there will be more available to, potentially go to different spots and different clinics, right? All 15 of the, when we give out the bursaries, they all have to come back. And they're all going to be looking for clinics to go to. That's it. Well, folks, if there's nothing else, then I think that's all I have to say. That went uneventful. Good. Thank you.